Welcome back to another episode of the AltMed podcast series. With me today, my co-host Mitch, and
Hey.
we've got a very special guest. But before I introduce, I just want to say to everyone, please hit subscribe. I don't know where you're getting your feed. Are you listening to this on Spotify, the Apple podcast app, YouTube, whatever it is? In fact, just stop listening right now. Go and hit subscribe and then come back to this video, okay? We'd love to get some more subscribers. We can see you're all listening, you're all viewing the videos, but yeah, we just want to build that subscriber base.
Yeah,
So
I can smell the desperation. It's great.
just get on board. Get on board. Mitch, you love a subscriber. I know you do.
Always have.
It is our great pleasure to introduce our guest today, Dr. Shu Ng. How are you, Shu?
I'm good, thank you. Thanks so much for having me on.
It's a pleasure always to have you around and have a chat. We've enjoyed a few in the past and very happy and excited to put it on camera this time. So
That's
yeah,
right.
thanks. Thank you. I think as per usual, we kick off with a little bit of a background for those who may not have come across your name just yet, for the very small few in the community.
I was going to say there would only be a handful that haven't, given you
maybe.
Cannabis in Australia. But yes, if you wouldn't mind taking us through your background, that'd be great.
Yeah, thanks. Sometimes when people ask me that, I go, where do I start? Because I've been practicing medicine for 10 years now, since I finished medical school over 10 years ago. And I just did so many different things between surgery and sort of thought, I don't think I was cut out to be a surgeon. So then I was really interested in cancer care and just really had a lot of heart for patients with cancer. And so then, and I did a lot of breast surgery in the past as well, but then I sort of thought, what's the other, arm of oncology? And I delved into radiation oncology, so treating cancer with radiotherapy. And I did that training for 3.5 years. So I've learned a lot through there as well. And I also went to the States for a couple of years to do a research fellowship in New York City in Memorial Sloan Kettering. So all those were just really good experiences. And I guess it just gave me a really broad overview of, medicine in general. But it was not only till when I was doing oncology that I had so many patients with issues like chronic pain and nausea, vomiting and things. And I do remember having a patient undergoing radiotherapy, and I was asking, oh, how's your pain going? And they went, yeah, it's I started on medicinal cannabis. And this must have been about 2016 or 2017 when it was really first legalized. And I was like, oh, medicinal cannabis? What's this like hippie backyard medicine? Never really know if it was, a real medical thing. And so it really sparked my interest then, I guess. I left it for a bit. And then later on saw that Canadoc clinics were hiring, and that was over a year ago now. And it's just incredible, the kind of patients you see and the outcomes you get as well. And I really just thought it was something to just have some experience in, but it's just been so fulfilling. Patients have such good outcomes and effects and you see such a wide range of patients as well. And even though I still have a good sort of interest in cancer care and palliative care, and seeing how underutilized medicinal cannabis is, but even then seeing a wide range from mental health disorders to chronic pain to multiple sclerosis. Even just today I had someone who had asthma, and he just had so many different inhalers, and he goes, I'm just at my wit's end, what else can I explore? And so it's just an ever evolving field.
That's
so yeah, a bit of a background.
That's so let me get this straight. So you finish up at med school, you had your 2-year fellowship over in New York. Was that in as part of your training in radiation oncology, or was that separate?
Yeah, no, that was separate. So I did, a couple of years in general medicine, general surgery in Australia first, and then I sort of did some unaccredited time in non-training time in radiation oncology, and then went over to New York to do a research fellowship in GI cancers, and came back and then started radiation oncology then, but although my research was also in sort of radiotherapy related subjects as well. So yeah, so I came back and then did three and a half years of radiation oncology training. And then after I worked a little bit in, medical visa, immigration visa rather, work and things, and even some COVID related things as well. So it's certainly been quite a journey in the past year, especially with COVID too. But yeah, it's very, very broad experience, I suppose.
Well, you do, and that really, I think sometimes we hear the term, medicinal cannabis clinician or medicinal cannabis doctor, but it just kind of goes to show how broad the background of the person that you might be seeing that carries that title. And although I appreciate that, you're not officially titled an oncologist, it's great to have you on, because I think that your experience in, as a trainee in that field would lend itself really well to having a discussion about, the role that medicinal cannabis plays in assisting people living with cancer. Of course, it's, as we always say on this, it's not appropriate for everyone, and these are discussions between patients and their treating doctors. But perhaps if it's possible, it might be good to just jump into that topic and see. I think there's a lot of confusion around what the role that medicinal cannabis plays in somebody's oncology treatment. Can you perhaps talk to us about when it is prescribed, and how some of your experiences with your patients? If any stories that you have or anecdotes, we'd love to hear.
Yeah, absolutely. It's really interesting because, especially having that sort of oncology experience, sometimes I do inevitably put on my oncology hat as well and talk about that sort of thing, based on my experience too. So, medicinal cannabis at the moment, it's not, the indication is not for cancer treatment. So it's not meant to replace chemotherapy or radiotherapy or immunotherapy in the treatment of cancer. But what, is quite helpful, we know that patients who have cancer or have had cancer treatment tend to experience a lot of symptoms like anxiety, chronic pain, whether it's from the cancer or from cancer treatment, because radiotherapy can sometimes have a long-term effect with inflammation and chronic pain, but also with cancer treatment related nausea, vomiting. And quite often also, lots of these patients with cancer or undergoing treatment are on some form of steroid therapy that causes, insomnia. And so it really is used more at the moment anyway, not disputing that, 10, 20 years down the road, it might be used as some form of cancer treatment. But at the moment anyway, what's been shown is that it does help as an adjunct, a supportive therapy for patients who have, the previously mentioned symptoms, to help with them with their cancer journey. So, I do tend to get a lot of, you watch, these documentaries about how, I think some people in Queensland have treated cancer, and cancer have regressed with CBD oil or topical treatments and things. But all those are just, I'm not saying that it didn't work for those patients, but it's not something that's been put to rigorous testing. We don't know what dose works for people. We don't know what formulation works for patients. And so it's still, quite an unknown, but we know that it's quite helpful for patients who have symptoms surrounding their cancer diagnosis or their treatment. I guess I also have, patients, like I had a patient with GBM, so advanced brain tumor, who had surgery and had 3 weeks of chemoradiotherapy, and he was quite, he didn't really have any symptoms, but the family, and fair enough, they were quite concerned about some residual cancer, and they read on forums that medicinal cannabis can help with tumor regression, and they're not wrong, but those studies are done mainly in animal models, for example, to show that maybe a balanced THC CBD might be helpful for tumor regression, but it's not something that's necessarily been proven or shown at the moment in in real life patients, I guess.
And that's the point as well. I suppose under the current framework, nothing would prevent a doctor from at least making the application. But to date, I don't think we've seen any approvals from the medicines regulator that's handling these special access scheme applications, where they're saying, yeah, for this oncology condition, we accept medicinal cannabis as a therapy option.
I guess, it's sometimes, especially with these applications, you want to be quite careful with the way that you say, you justify why you're trying to apply for the medications, because even though TGA say that it has to be a, not necessarily last resort, but it has to be something, a condition that you have tried and failed other therapies. And in the case of something like advanced cancer, they might not have any other chemotherapy options, and they might not be able to have further radiotherapy, or they might not be a candidate for immunotherapy, in which case they don't have any other option. So then, technically they come under they can apply for things under criteria of, having tried and failed multiple medications. But at the same time, the question is more about what are you trying to achieve? Because do we know what dose is going to help? Potentially,
Yeah, I was just thinking as well, there is a separate category under special access scheme that's often not talked about. I know that for most people who are going through the special access scheme pathway for accessing medicinal cannabis legally, they would go down the category B, but where you have to make an application and actually receive an approval or an authority from the TGA. Whereas I think, is it SAS category A, is
category
it?
A, yeah, that's right.
Category A is simply just you give notice to the TGA that you are prescribing an unapproved therapeutic good, but it's only for situations where the person has a terminal illness, so it's an end of life treatment. Is my understanding correct there?
Palliative.
Yeah, so that's a very good question, because I looked into it a lot as well, because now that you're mentioning it, I do actually have a couple of patients that saw me because we were trying to help with symptoms like nausea because they had brain metastases, like brain tumor in the brain. Someone else had quite advanced cancer as well, and while I was trying to go through the SAS-B application, by the time so one patient, once I got it back and sent the script to the pharmacy, she had passed away. And then another patient who, just before I got the approval, she had passed away. And this is not something that was quite, expected as well, because I thought that they might maybe still have maybe a few months potentially, but this is the thing you never really know. But you're right in that the SAS category A allows for so it's a notification process for patients who potentially have a terminal illness that gives them maybe a few months to live, but they could have either pass away or have deterioration within, unexpectedly. But the issue with that is that the ODC, or the Office of Drug Control, has made it such that patients who go through that process have to have a product that's imported, but not one that's imported through the government. So not the ones that you already have here from Canada or wherever. So that scheme is really for the scheme, or that category is really for patients who want to import their own product from overseas. But again, the issue is that then you might as well go through the category B, because that would be quicker than trying to get importation license and things from overseas. So
yeah, that's
so why they have that category, don't really know, because they make it quite difficult. It's not like you can already have the medication here and then have that notification process. So there are you have to first get that notification and then go through ODC to get the importation. And so there is actually, I'm not sure if you guys have seen, but on the SAS portal, when you click through either SAS-A or SAS, whichever route you want to go through, under SAS-A, there's quite a long paragraph that says, note that the time of processing, even though it's within 2 days, but by the time you get the importation through it will be longer, so much so that the SAS-B will probably be a quicker way. So there's actually a paragraph that says that. And that's
really
why.
what they need to do is amend the regulatory framework to enable, because at the moment, category B, as we mentioned before, is an application and then you await approval, whereas category A is just simply give notice to the regulator. But of course, if you're then confined to a separate personal importation scheme,
absolutely,
it just renders the whole thing futile, especially.
It defeats the purpose, actually.
Yeah, time is of the essence. Very interesting.
And so
that's right. So it's sorry, go on.
No, that's okay. I'll let you finish.
Oh no, I was going to say, so sometimes I guess it depends on the approval times as well, because sometimes I get the approval within 2 hours. Somehow it's really quick. And sometimes I get the approval within 24 hours, but there was, a period of time where the approval was 7 days. So if the SAS-B approvals come through quickly enough, it doesn't really affect things too much, but it's more that it's very unpredictable with the processing times. But absolutely, I think there should be a separate scheme where you can just notify because you really want to get these medications out to patients urgently.
Yeah, absolutely. But in terms of coming back to the chat about cancer, what are the more common, things you would prescribe for? Is it more nausea? Is that probably the most common indication that you would actually apply for special access to?
So it's interesting because I think it's a combination of a few indications. So for example, I have a patient who's had breast cancer and radiotherapy and chemotherapy, and she, is that connection okay? Oh.
Yeah.
So she's got a lot of anxiety surrounding her breast cancer diagnosis and the treatment previously, but she also has a lot of chronic pain, so like nerve pain after surgery, because they tend to affect the underarm nerves and things. But she also had insomnia. So then a lot of these patients have not just one issue; they have multiple issues that medicinal cannabis could be beneficial or could be beneficial for. So that's one patient. I've got another patient who has active esophageal cancer and has a lot of nausea, vomiting. She's like 90, and she had a lot of weight loss as well, and she wasn't eating, and now is on medicinal cannabis 3 times a day, and she's eating and she's put on weight. So it's really a mixture. I can't really say that there are certain indications that's more prevalent with these patients, because most of them tend to have multiple indications that medicinal cannabis could help them with.
Yeah.
But that's the thing that is very helpful, because you might have patients with nausea, vomiting, and pain. They might have to have a myriad of medications to help with all those problems. But medicinal cannabis in the good formulations or different formulations can help with a lot of these.
Yeah, and I think that's
simple sort of tailoring of medication.
I think that's something we hear common, patients with maybe a combination of sleep disorders, anxiety, pain, they kind of all get attacked by cannabis, if that's the right word to use, or remedied to some description, potentially in terms of trying to figure out combinations of polypharmacy that might work together. Very interesting. And can I ask, is it more, do you find you're more reaching for the CBD or THC scripts, or a combination with these types of prescriptions?
No, that's quite interesting, because I guess a lot of it's not just about the indication and what THC and CBD might help with. It's also about the regulations around driving is the main thing for people as well. Because just because if I think that they have insomnia and they might benefit from something with THC at nighttime, we have to still be very careful about advising about driving. And some people will go, okay, well, no, I really can't, because I have to drive every day, or 200 km a week and stuff like that. So that's the barrier to them accessing particular formulations. But I would say that a lot of these patients, because of the nature of the symptoms they have, a lot of them mostly benefit from some sort of a balanced medication to help with, whether it's mood-related disorders, but also pain and appetite and insomnia. So balanced ones are one of the most common ones, but also depends on time of day. So if patients just go, oh, my steroid's is causing me to not be able to sleep very well, I just need something at nighttime, then THC medications are very helpful. But I also have patients who just have quite severe anxiety and want to have just a CBD based medication to help with the anxiety. So it is a whole what do you call it? So lots of different medications I would prescribe for depending on the indications.
Excellent. Did you? I'm just curious. Also, in your time, I know that you would have gained some really valuable experience in your in your burgeoning medical career during your time at Canadoc, because I feel that Canadoc, at least to my knowledge, was one of the first cannabis clinics. So, what did you pick up on then, and what kind of? I assume you were prescribing cannabis for a broader range of medical conditions than oncology symptoms or anything like that. So, can you share your experiences with that clinic, perhaps?
Yeah. So I guess the nice thing about a clinic, because it gets triaged through potentially like a reception team, and they would, give or send patients to whomever has availabilities and when patients can make it. But it was very interesting because you had such a wide range of people who have obviously found the clinic through, different means. But patients with multiple sclerosis, chronic cancer, non-cancer pain, anxiety. It was a good clinic to really have a lot of exposure to lots of different conditions and really start to think about the different types of formulations and medications that could potentially help these different conditions, but also start to realize that just because 10 patients have the same problem, like 10 patients have chronic pain, they all have different dosing medication regimes, and it was a very good experience to garner a lot of experience in managing different conditions.
Yeah, fantastic. In terms of since Canadoc, you're obviously now doing an independent cannabis clinician practicing. I would love to hear a little bit about what this next frontier holds for you in terms of what patients might need if they were to see you.
Yeah, it's funny because today someone else had asked me the same thing. They said, "Oh, is there anything that's different to what you're doing at Canadoc versus what you're doing now?" I think that's the other good thing about Canadoc, that they are, practitioners and doctors are allowed to be quite independent in how they prescribe and how they manage patients. And so, when I start out my independent practice, I don't feel very much different to how I practiced before. I think certainly at the moment I'm doing everything by myself, so I don't have administrative help. So that's one thing that's different. But I still spend the same amount of time and care with patients and education. And I think that at the moment lots of patients have been finding me either through pharmacies, or I had a patient who emailed me on my website and said, "Hi, Dr. Shu, I was just wondering if this is your old practice or new practice, because I just wanted to see you and continue our care." Because fair enough, some patients I've seen, for 6 months, a year, and they just want that continuity, and that's okay. But I think that because I was so flexible and independent already as it is in Canadoc, that it pretty much feels the same, just maybe on my own.
Yeah, fair enough. And in terms of, you go, Andrew.
I just had a question about that idea of being independent, because I think it's particularly becoming more important, I suppose, because we are seeing different clinics have ties to, certain products and things like that. I suppose just being independent, is your observation that there is a standardized level of care and treatment across cannabis doctors around Australia? Or do you find that sometimes a patient might go to one clinic and get given a product and then could go to another clinic and the doctor might have a completely different view based on, commercial arrangements behind the scenes that patients don't necessarily have access to?
Yeah, absolutely. It is an interesting question because even in my time in Canada, I've had patients who were patients of other clinics that had vested interest in specific products, and whether or not those products weren't really suitable and they couldn't really prescribe anything else. And so they've come to us or other doctors that can prescribe pretty much anything on the market. And I think that having a clinic or a doctor that prescribe solely specific products is probably easy for them because there's only 5 different medications or whatever it is that they have to really familiarize themselves with. And the difficulty with someone like myself being an independent practitioner is having to be familiar with everything, but also knowing the options and really trying to choose medications that are tailored according to patients. And I quite like that. And I always tell patients as part of my initial consultation that I don't have any financial interest with any companies and medications. So I prescribe what suits you best. And I think that patients do appreciate that flexibility and being able to choose or access products that are available to them. I have patients who go, oh, I've got one of my friends was on this medication and they have the similar symptoms to what I have. So I'm wondering if I could try that. And yeah, sure. If this is something you would like to trial and I think it's appropriate, then sure. But I can imagine that other clinics will just have their own agenda about prescribing certain medications. And I think it's not necessarily, in my opinion anyway, the most ethical way to go around things. I think patients should have the option of being given different choices. But I certainly think that, like clinics like Canada and certainly lots of clinics where you have that freedom to choose whatever products you think suit best and works well is, I would say, a good way to go.
It is, because you get, I think the other pathway can restrict patient choices ultimately, whereas if a doctor's free to really just prescribe whatever product they deem is appropriate, they have a lot more latitude to work with the array of legal medicinal cannabis products that are available in Australia at the moment, or indeed, write a compound script, whatever they might choose to do. So no, I totally.
I think it is a unique industry in a sense where, I'm not sure, you might know better than I, but other medicine areas, you wouldn't really ask for a brand name necessarily. In other, you might say, look, I prefer Panadol to paracetamol from the generic, for example. But beyond that, you're not like, oh, I feel like trying this strain or this type of product this week, or it's literally the same product. But
can I get a full spectrum Nurofen, please?
Yeah, exactly.
Just imagine.
but it's like you don't really find that variation batch to batch in a single kind of product or a single active ingredient. And I think you're finding there's a lot more variance, at least I'm sure in your experience, or maybe you can tell us the types of products that you're looking for as a prescribing doctor. What seems to work better? What seems to work more effectively? I know it's very nuanced depending on the patient and their indication, but are you finding kind of general trends?
Yeah, I think that it's hard to really necessarily say that there's one thing that influences choices and things, but cost is a big factor. There are the medications that, say for example, balanced medications that can work. I've got patients who've tried different balanced medications and go, oh, they all work pretty similarly for me, and so they choose the one that's most cost effective, for example. But then it's also about, let's say, TGA or medications that you apply through TGA, so the shelf medications that are the ready-made, if you like, medications. Sometimes choices also revolve around the formulations that brand might have, that you might think that might work well for some patients. And yeah, like you mentioned, also like full spectrum isolates, whether a brand has an isolate and patient might want to try an isolate. And also, it is nice to have that choice. I've had patients who've had certain brand medications and then switched over to a different brand with the same supposed formula, like THC content, and they tolerated that better than the other ones. So, it is like how I guess influences my choices is about patient indication, and whether we think about certain formulations, also patient experience, what they've had before or what they know has worked well for people that they know and they want to try the same thing, for example. But it's hard to really pinpoint things, because it's just such a variety of reasons as to why you might choose a certain product. And it can be hard for practitioners like myself, I guess, who's who has freedom to choose anything, to really keep abreast of all the different medications. But when you find a brand and formulation, or most a brand that works really well, that is of good quality, that you have good communication with the distributors or the suppliers or the companies, that's quite important. And support also, because there's sometimes I want to ask somebody about medications and about indications and things that might be a bit curly. And it's nice to know that there is support from different companies, and some companies are more, ready with their support than others. Mm-hmm. So that is sort of a determining factor for, I think, relationships with companies about support and things like that, for not just practitioners but for patients as well. I actually had a patient who said that, oh yeah, I spoke to the director of who supplies this of the company, and we talked about the types of medications that could help. And so sometimes patients go, I want to go with this brand because I've spoken to this guy. So yeah, lots of reasons why you choose like different brands.
Yeah, I was going to choose a medicine at Amcal the other day because I was speaking to the CEO of Pfizer, and I was just like, what do you feel like?
That's it. That's right.
Yeah, it's a little bit different at the moment, I'd say. Here.
Yeah, but the other thing also actually just reminds me that that I do have patients who go, are these Australian grown? Are these Australian made? Are these Australian companies? Because I want to, especially during COVID times, they go, I want to support Australian companies and things like that. So that is actually also a consideration for some patients with the source of products and things as well.
That's interesting. Yeah, absolutely. Yeah, I've heard increasingly people, and I think people trust the Australian quality
absolutely
at the moment, or in general, over the years, we've got a great reputation pharmaceutically. And, just look at even not in baby formula, for example, just the quality of production is, a different level. So,
that's right.
Yeah,
absolutely.
You're going to say, Andrew?
Oh, no, I was just thinking, there's at the moment, the marketplace is a bit of a, quite a hybrid model between imports and domestic. And, there'd be certain imported products that I think wouldn't be made available domestically. So it's a bit of a difficult one, but I fully understand the thinking of it is good to support local industry. And, I think we're moving towards a spot where I think in the fullness of time, we'll have quite a comprehensive product offering that will be all grown and manufactured domestically here in Australia.
Yeah.
And we're just not there yet, but we're well on our way. There's some really exciting local projects that are on the ground, and yeah, we'll just watch and see. Really,
it's one of those funny ones where sometimes depending on your, I guess, maybe your social circle, but sometimes people see, for example, with cars, like, oh, a German car is a sign of quality, for example, versus maybe potentially some Australian ones in the past, not all, but some. But I think there's
like, do you get a Holden V8 solid product, or do you get an Audi broad spectrum. That doesn't work, does it?
That's right.
I'm more talking about the sterility, but the Australian grown is very, yeah, I'm seeing not just demand in Australia, but also overseas. You're starting to hear people be like, oh, it'd be interesting to see, Australia's got the right climate, the right weather to produce, and the standards of production are very high. And we're seeing that now where everybody else, for example, America and North America, has kind of rushed into producing cannabis, and the quality that's coming out there varies greatly.
But we have so many different microclimates here as well. I mean, it's kind of, you look at where all the different sort of cultivation sites are operating from, there's regional Vic, regional Queensland. I mean, there's just such a breadth of different climates. So, but yeah, we're, as you would know, Shu, we follow along the industry at a cultivation level, a clinic level. We just keep an eye on everything. But yeah, it's exciting.
But
very exciting developments, yeah.
Definitely a question that I think is great. Whenever we have a medical practitioner, we're always very interested to know what are the most common questions you get. What are the for the patients out there or prospective patients, people thinking about maybe switching from black market to legal market, things like this. What are the important factors they need to know about accessing medicinal cannabis in Australia, and some of the major questions that you get asked?
Yeah, I guess the number one question is, can I access it? So, about eligibility and things, which really isn't, I think maybe 3-4 years ago, there was a thought that it must be last resort. You must have tried and failed like everything on earth before you can access medicinal cannabis. And we know that's not true, because, you might not want to try, 10 different pain medications or 10 different antidepressants before accessing medicinal cannabis. I mean, a lot of them can work quite similarly and give you the same sort of side effects and things. And so you might have tried one and then don't really want to, give antidepressants or other pain medication a go. And so, the eligibility criteria is the main question that people want to know. Can I access medicinal cannabis if I have had this medical condition? And so, yes, if they have a chronic medical condition that's diagnosed and investigated in the past, and have tried some form of medication, and whether it's partially effective or they've developed side effects and couldn't tolerate those medications. So quite a lot of people who are interested can actually access these medications because they would have, either spoke to their GP about it, have had some form of therapy previously. So that's, one of the questions. And the other main questions are also, what do I have to be smoking weed to be considered medicinal cannabis? And no, because I had that conversation today as well. And he's like, no, I don't want to be smoking anything. What else is there? And so the forms of medicinal cannabis, whether TGA approved and things or compounded, but also what administration routes and the type of products are usually also quite question people ask, but also cost, because I guess they would say 3-4 years ago it was really expensive in the grand scheme of things. But then in the recent times, as demand has increased, it's really driven down the cost for patients as well. So it becomes a bit more, because it's so cost prohibitive before, and now it's not the cheapest medication, but it's still something that can be affordable for patients. And it's something that people, even in the medical industry, some doctors will have patients tell me this, and my doctor said it was very, very expensive, and so they didn't recommend it. And then when I tell them about, average price, and if, we prescribe something, this is the cost, depending on how much you use, they go, oh, this is like, 3-4 times less than what I thought it was going to cost me. So that's great. And, so yeah, I mean, definitely those are, I think, the main questions that I get from people.
Yeah. I think that's pretty consistent with what we hear. Can I access it? Am I going to get high?
It might be worth also just if you could, what are some of the, because I think there's maybe an assumption from a lot of people that might be going to visit a cannabis doctor that, I'm going to a cannabis doctor, I'll be able to get legal cannabis. But I suppose to dispel that myth, what are some of the reasons that you would choose not to prescribe a patient cannabis?
Yeah, great question, because certainly I've had to, so reject is a very strong word, but I've had to, decline some patients or say that it's not appropriate or they're not suitable.
Not a
Exactly.
hard rejection. Get out of my clinic now.
That's right. But also, I think a lot of the times people want to know the reasons as to why they might not be suitable and things that they just don't know. And when you sort of explain that, they go, okay, well, thank you for letting me know. Actually, my time in Canada, there were times I looked at referrals for the next day, and even seeing the patient's referral going, oh, I don't think they're eligible, and I'll give them a quick call and just have a quick chat for free. But go, and they go, oh, thanks so much for telling me. I didn't know this. I'll do this and that and stuff like that. So in terms of reasons, I guess, if somehow they didn't get through to the eligibility criteria, or someone going through the eligibility criteria with them, then that's one of the reasons. If they actually had some acute problem, like I fractured my leg, 2 weeks ago, and I want to start medicinal cannabis, or they actually didn't try any sort of conventional medication. Not necessarily that I agree that you must have tried something, but that is a TGA requirement that you must have tried some form of, registered medication, conventional therapy before actually accessing medicinal cannabis. But also other things like previous history. So if they've had a history of schizophrenia or psychotic disorder, I'm not saying that it precludes them from accessing medicinal cannabis, but they must have a psychiatrist involvement who is, happy with their progress, or is stable under medications, or maybe they haven't had a psychotic episode for years, and there's a psychiatrist supports them using THC-based medications, for example. So,
what about also, just on that one? Sorry, just curious.
Yeah.
Like family mental illness history. So, if say, my uncle or like someone close, or brother or something, like what would be the response? Is that just more background for the doctor to sort of really monitor a little bit more closely, or could it actually be a material decisive factor in saying, hey, sorry, your sister had schizophrenia, I'm not comfortable prescribing to you?
Yeah. So it's really about that knowledge of what the family history might be like. But also I think it's also on the TGA website, I think, that if you want to not preclude, but then if someone has a strong family history, so you say I've got 5 brothers and all of them have schizophrenia, and I just I'm 18 or 20 and I don't have schizophrenia, but maybe it's still it hasn't shown itself. And so some of the issues with THC, for example, is that it can unmask schizophrenia in younger patients. And so it's more about the strong family history, but I don't necessarily mean that it absolutely excludes them from having any form of medicinal cannabis, but it's more about knowing the risks, also being able to think about what sort of formulations you might choose. Maybe don't choose either THC free or low THC medication first, but also having them make sure that they have the appropriate specialist care as well if something should happen. But it's definitely it's something of consideration. Like I had a patient who has chronic fatigue, but her mom had bipolar, her sister had bipolar with psychotic episodes, and she was really, really worried that if she took anything with THC, that she would have the same sort of problems. But it took a lot of education to work out how her sister had or why or when her sister had those symptoms. We deduced that it was more drug related, that her sister developed psychosis, and so eventually she moved on to THC medications with no problems. So it's a lot about trying to elicit what the risks are, than actually saying, nope, you've got a family history, nope, your uncle, your great uncle had that. So yeah.
And do you find when you do politely decline somebody's interest in receiving a medicinal cannabis treatment, do they furiously take notes about your reasons and then find their way to another cannabis doctor to try and get it right the second time? Or how does that often play out?
I'm sure you must have heard stories then if you're asking the question, because I certainly have had, someone, so because the idea is that you want to make sure you're prescribing things as safely as possible. And so, I've had a patient who had a psychotic episode like 10 years ago, and sure, maybe it was 10 years ago and maybe it hasn't happened since. And I said, well, I still do need an underlying mental health disorder. I said, still, if we could get some form of a clearance or something from your psychiatrist, and people have done that, they've gone to the psychiatrist, had a few sessions, and I said, okay. But like this particular patient just went, no, thanks for your help. I'm just going to call a different clinic and not tell them that I've had this episode. I'm like, okay, but what can you do? Right?
Yeah, exactly. By the way, we just got a cameo from Ava, which was incredible. Your lovely Ava, just wandering around in the background, just a very interested audience member. Love it.
Just staring here.
It's very 2021. Bring your dog to work day.
Yeah,
it is, because look at this now. She was I'm at one of those like sit stand desks, and I've got my table's quite high, so she usually just jumps on my lap, and she's done that when I've been with patients. But this is too high for her to jump, but she loves to make an appearance because she's a princess.
I'd love to say
bring your dog to working from home day.
Bring your dog to working from home day. I'd love to say it was the first dog we've had on the show. Unfortunately, it's our second.
Darn it.
Old Steve's CBD reviews.
Yeah,
Ava's lovely. For those listening, we are just looking at one of the cutest dogs I think I've ever seen. Lovely little Ava, the Italian greyhound.
If your last name is NG and you're on our show, you've got to bring a dog.
Yes. That's it. Well, that's probably a nice note for us to wrap up on. If unless you had any more questions, Mitch, I feel like or alternatively, I'll put it this way. Given that we wax lyrical with Shu from time to time anyway, I'm sure we could possibly persuade her to come back on for another episode.
I'm sure there'll be plenty to speak about in the future. Yeah.
Because we'd also love to hear, because I mean, just now that you've been in a clinic and now you're going to be operating independently as a cannabis doctor, would love to hear about all the trials and tribulations as you start the journey on this front independently.
Yeah.
I'm going to cap off with the question that we like to ask at the end here, which is, do you think medicinal cannabis or cannabis will be available recreationally in Australia? And if so, what timeline?
By the way, I was talking about this question recently with another mate, and they said cannabis is already available recreationally
in ACT.
Well, yeah, or wherever. But anyway, no, I'm just trying
to legally.
Oh, sorry, legally. Sorry. Just caveat there. I was just trying to give a shout out to the black market listeners out there. But no, sorry, Dr. Shu. Any ideas on?
I think everyone. I think I sway here and there, but my opinion is still that we're quite honestly backwards, but also very conservative in very many regards. I mean, even when I was doing radiation oncology and was very much technologically based and things, and I always used to say, I think that we're kind of like 5 years, not more, behind places like the US and things, with in that industry. And I think that if with medicinal cannabis, and actually legalizing recreational cannabis, but you're right, Mitch, it is legal recreationally in ACT, but I don't know. I'll be very obviously depends on who's in politics and who's the major party, but also I don't know. I would not think that it would be like I'll listen back to this 5 or 10 years later and see what I said and whether I was wrong or right, but I don't think it will be legalized recreationally, at least in Victoria or maybe other states in Australia for another at least like 5 to 10 years, I think. But you really don't know how the scene changes. It's so dynamic, and I think that, like you mentioned, with the recreational users and the listeners out there, are they holding on to hope that one day it's going to be legalized recreationally? We're certainly seeing a lot of that happening in the US and other countries as well. And I think what's going to happen is that Australia is going to take some years, take a few years to see what the impact or long-term impact is on those countries first, before actually having some form of data to say this works well, it doesn't increase crime and road-related things, so injuries, and so I think it would take a good few years before they actually come up with that data and think about whether or not they want to pursue that.
No, I think that's
interesting.
Safe for some. I think 5 to 10 years is generally in the range that we're hearing. So take note, politicians. I mean, hopefully some of them start listening more to Fiona Patton. But yeah, take notes. 2026 to 2031. If it's not done in that period, you're going to get a backlash from.
I think we saw ScoMo's IP on our viewership list, so we should be all right.
Well, then it's going to take a lot longer. To be honest. Anyway, all right. Well, on that note, we might wrap up, but we'll definitely do this again, Shu. It's been an absolute pleasure having you on, and Ava as well. Big shout out to Ava.
Yeah.
We look forward to welcoming you both back on, and maybe we might get a cameo next time from your other lovely dog
from Vino. Yeah, I don't really know what he's up to now, but yes, Ava does like an appearance, so not surprised.
A little bit camera shy. No, we get it. All right. Thank you so much, Shu. We'll speak again soon.
Thank you.
Yeah, thank you.
Bye.